Welcome, doctors. Good morning. Welcome to our 10th session of recall-based discussion. Here we have a list of topics. So first, let's do this incomplete abortion. It's not very much in detail in MTB. So let's have a look at AMBUS for incomplete abortion. So we have certain types of pregnancy loss, and there are a lot more categories in this one. So we'll quickly go through each category and we'll focus more on threatened and incomplete as per the recalls are based on these two topics. So first we have threatened abortion, a process of miscarriage that has started but not yet progressed to state for which recovery is impossible. So still the baby is alive, everything is under control, but the patient is presenting with minimal pervaginal bleeding. We can say it's a threat to the patient's life, of course, and the fetal life, but still the condition is under control. If we ask our patients to relax and do the bed rest, proper bed rest, IV hydration, proper diet and everything, we can still continue the pregnancy. So before 20 weeks gestation. So time period is always for threatened miscarriage. In order to make a diagnosis of threatened miscarriage, the patient should be vitally stable, the fetal heart should be there, everything should be intact, but still there's a pericyte bleed, which is pointing us towards that to make a diagnosis of threatened miscarriage. And the pregnancy loss, just 1 minute. So the loss should be before 20 weeks. So if the question says like 16 weeks pregnancy, 14 weeks pregnancy with mild PV bleeding, but fetal hearts are audible, patient is vitally stable, so we can make the diagnosis of threatened miscarriage. So what we are going to see in our patients, the patient must be presenting with vaginal bleeding, there must be fetal activity and closed cervical os. So on examination, if you see, there will be closed cervical os, there will be no opening. You're not going to feel any RPOCs or any product of, conception in the vaginal canal or cervical canal. It's something not like that. So that's why we are saying its pregnancy is all secured and we can continue with this one. So what we are going to do, we will do this expectant management. Expectant management includes that we will hydrate the patient, we'll ask the patient to, for the strict bed rest, we will maintain the input-output charting, we will ask the patient, to avoid any strenuous work or heavy exercise, something like that. That patient should be totally restricted to the bed, and we are going to provide some progesterone support to the patient. Just in order, progesterone support is not going to do much to the patient, but it's, it's just a supportive therapy to help the pregnancy, in other words. Now, avoid strenuous physical activity. Weekly pelvic ultrasound we are going to rule out treatable causes of vaginal bleeding. If the patient is Rh negative, of course we are going to give anti-D to the patient. Now we have the another type, that is inevitable abortion, a condition of vaginal bleeding and cervical dilatation without expulsion of product of conception that occurs before 20 weeks gestation. So here you will see the patient must be having vaginal bleeding and the cervix is open. Of course, when the cervix is open, right now you are not feeling anything in the canal, but still the RPOCs are inside. But soon, this RPOCs are going to be expelled out. So typically followed by partial or complete passage of product of conception. So sometimes we may find something in the vaginal canal, and sometimes we don't have. The canal is totally empty, but os is open. So once os is open, so by far or now, any day in a 2 or 3 days, you will see that the product of conception will be expelled out. So patient must be having vaginal bleeding, and right now maybe the fetal hearts are there, but as the cervix is open, we cannot help the patient. The patient may expel product of conception anytime. Fetal activity may be present, but because of the dilated cervical os, there's a less likely chance that we are going to help this pregnancy. We cannot help this pregnancy. Anyways, that the product of conception has to be expelled out. So we'll wait for the expulsion. Nothing much to do here. And we'll vitally monitor the patient, that the patient should remain stable as the patient is presenting with the vaginal bleeding. Then we have missed abortion. Missed abortion, death of a fetus before 20 weeks gestation without expulsion of any product of conception. So for example, you can say it's a missed miscarriage. In other words, this 9 weeks pregnancy, 10 weeks pregnancy is there, but with no fetal heart. So it means that the fetus is already dead without any expulsion of product of conception, or sometimes you will see no bleeding at all, no expulsion at all, but of course the fetal heart will not be there, and there's a closed cervical. So there's a less likely chance that this is going to be remain inside the body. Of course, with the passage of time, maybe in a day or two, you will see this product of conception will be expelled out, as there is no fetal activity. The uterus is not going to retain that thing. Uterus is going to expel that thing out, but it will take some time. Maybe we can help the patient, or the patient by herself, the uterus will expel it. So here, in case of missed abortion, in case of missed miscarriage, there will be no fetal activity. The presentation is like that. 9 or 10 weeks pregnancy with no fetal heart, there will be no symptoms at all, but of course the uterus is going to expel this one. So depend upon mostly on the patient preference, what patient wants to do. If, anyhow, by 14 weeks the decision should be made. Say for example, if the patient is willing to get rid of this product of conception, we can just dilate the cervix and we'll perform DNC, and we will just remove this one. Or maybe we can go for suction and evacuation with the help of this manual vacuum aspiration. We can go for that, or maybe DNC. But nowadays we really don't prefer DNC. If the gestational age is below 14 weeks of gestation, we always consider for this manual vacuum aspiration. So we have medical evacuation as well. We can put this mifepristone and misoprostol. This is a medical, in terms of medical abortion, we can say this one. But of course, based on the ground that there is no fetal heart, and of course the mother is stable. Surgical evacuation, of course, dilatation and curettage can be a choice, but it can lead to, but does not occur after 4 weeks or in case of septic abortion or heavy bleeding. So if a spontaneous evacuation does not occur after 4 weeks, say for example, fetal heart, today the fetal heart is demised, no fetal heart activity. So we can wait till 4 weeks, but we should not go, for the DNC beyond that, because there are chances of having septic abortion in that case, because that product of conception may get infected with the passage of time. So we will not prefer this one. And the good thing is that as soon as the patient, stabilizes, the patient knows the fact that she has missed miscarriage, we should go for the medical treatment if possible. If not, we will go for the manual vacuum aspiration. And finally, the last we have DNC. So for the incomplete, so for the sake of our MCQ solve and recalls, we will go for incomplete abortion and threatened miscarriage in detail, right? So incomplete abortion, passage of some but not all product of conception before 20 weeks gestation. So of course, we will see some retained product of conception inside the canal, and of course some will be expelled out. So patient will give you a history that blood clots are actually expelled from the body. So vaginal bleeding of course will be there. Here you will see within the cervical canal or uterus product of conception, dilated cervical os, of course os will be open, usually occur less than 12 weeks of gestation. So incomplete abortion means that something is still remain inside the body of the mother and something is expelled out, os is open, so you have a chance to remove it manually as well. So this is incomplete abortion. For complete abortion, of course, everything is expelled out, os is closed by now, and the pregnancy should be below 20 weeks. These are almost the same terms. But here you will see closed cervical os, because whatever is there is expelled out, and now the os is closed by itself. Stillbirth, loss of pregnancy after 20 weeks gestation, also called intrauterine fetal demise. So once the baby is like 30 weeks or maybe term baby is there, but it should be more than 20 weeks and fetal demise is there inside the body of the mother, we can say it's a stillbirth. Absence of fetal movement and cardiac activity, of course. The cervical os variable, sometimes it's open on palpation, maybe the baby is 24 weeks and 28 weeks and cervix is open, and sometimes cervix is closed. So spontaneous labor, in this case of stillbirth, we will always prefer for the vaginal delivery. So we'll wait for the spontaneous labor to occur, and it usually occurs within 2 weeks. So for especially if the baby is less than 20 weeks, we may wait till 4 weeks in order to do some medical intervention. Before medical intervention, we can wait for 4 weeks. But if the baby is more than 20 weeks and the stillbirth is there, we can wait for 2 weeks. So within 2 weeks, a spontaneous delivery should occur. But if not, then again we have to induce the labor. Vaginal delivery is safer than, of course, cesarean delivery, as we already know that the baby is having already the stillbirth has occurred, so we cannot do much to the patient. It's necessary not to harm the patient anymore. We'll prefer spontaneous delivery. So we can wait for 2 weeks. If the patient does not go into the natural labor, then of course we can induce the labor. So these two, especially for the recall point of view, just consider this threatened abortion, focus more on this one, and incomplete abortion. So threatened must know that the patient is stable, the heart rate is okay, the baby is okay. But the point is, because vaginal bleeding is there, so there is a threat to the life of the patient. So we have to go for the expectant management for this patient. But still, we have a chance that this pregnancy will progress, and we have to make everything possible. We can do any measures that will help the pregnancy to keep forward. In case of incomplete abortion, we don't have anything in our hand because the baby has already gone. Some product of conception has already expelled out. Some inside os is already open. So what we can do, we have to help the patient in order to remove the extra or the remaining product of conception which is inside the body. Let's have a look at the questions. Here the first question says, a 25-year-old woman gravida 5. There are two plus 2, presented to the clinic at 10 weeks gestation with painless vaginal bleeding. Sorry about that, it's OCR, and because of OCR, we do have some spelling mistakes. Okay, so here it's saying that gravida 5, now she is at 10 weeks gestation with painless vaginal bleeding. During her hospital admission, she developed heavy vaginal bleeding and lower abdominal pain. She has noticed passage of tissue, that is RPOCs. On examination, mild pain is there, vital signs are normal. Pelvic examination shows especially this melting or bleeding through the cervix, and os is open. Which of the following is the likely diagnosis? So what do you think? She is 10 weeks now. During her hospital admission, heavy bleeding has already occurred. She's having pain. It means that the uterus is going to expel. Something must be have expelled out. She has noticed passage of tissues. So already RPOCs has expelled. On examination, mild pain is there, but cervix is still open. So if all the products are removed from the uterus, the cervix has to be closed. That is a complete abortion. But when you do the examination and you feel that cervix is still open, and the patient is saying that I have noticed that some tissues has already passed, and on examination cervix is open, it means that there must be something inside. That's why some remaining part is inside. That's why the os is still open. So you have to remove everything, and then you will see the os will automatically close. So what do you think? What is the most likely diagnosis? Do you think it's inevitable abortion, incomplete abortion, threatened abortion, or septic incomplete abortion? Anyone?
It's A, inevitable.
Inevitable abortion, or do you think it's an incomplete abortion? Because see, the question is saying that the patient has saying that she has noticed passage of tissue. So some passage has already, some RPOCs has already passed, and some is still inside. That's why os is still open. So if you could just have a look again. Here, in case of inevitable abortion, you can see a condition of vaginal bleeding and cervical without expulsion of product of conception. So in inevitable, the patient will not say to you that I have noticed that some tissue has passed. But here in this scenario, in case of incomplete abortion, you will see that passage of some, but not the all product of conception. That's why the os is still open. So that's a case of incomplete abortion. Yes, this is a case of incomplete abortion. Threatened, of course, it's not the diagnosis of threatened, because for threatened, the baby should be alive. Septic incomplete abortion, the patient must be having symptoms of sepsis. Say, for example, fever must be there. So here, the presentation is not like that. Okay, for the second question, a 22-year-old primary gravida at 7 weeks gestation is brought to emergency department complaining of moderate vaginal bleeding with passage of tissue-like material and lower abdominal colicky pain. On speculum examination, tissues is in the vagina, uterine cervix is opened, and admitting one finger. It means that os is still open. Product of conception is protruding through the cervical canal. You can see some product is coming out. On bimanual examination, reveals bulky uterus. Bulky uterus means that something is still inside the uterus that has to be expelled out. Corresponding to 7-8 weeks gestation. Adnexa were free and there were no cervical excitation. So which of the following is most likely diagnosis? So again, this is the same case. Some tissue has already passed, some you are feeling in the canal, the os is still open, the uterus is still bulky, means something is still inside the uterus. So again, it's a type of incomplete abortion. Okay, but the next one we have to go for the theory first. So next we have premature rupture of membranes. We go for handouts 281. So So for premature rupture of membrane, as the term says, premature is still the baby is not mature. It should be the third trimester of pregnancy, the rupture of chorioamniotic membrane before onset of labor. So the leaking is there, the frank leaking is there. The patient, in lay term, we will say that the baby bag is ruptured or water bag is ruptured. So water bag, which has the whole amniotic fluid inside, that membrane, actually chorioamniotic membrane is ruptured, and all the fluid, you will see all the amniotic fluid is coming out, and that will give you a clue that it's a leaking. Sometimes it's a frank leaking. The patient will say to you that's a gush of fluid, came out suddenly, something like that. Or sometimes it's just like, leaking slowly because of the weight of the pressure of the baby. So anyhow, we have to go for the speculum examination. We cannot comment anything without seeing through our naked eyes. So it's very important whenever the patient says to you, complains to you, having a frank leaking or leaking like a urine, or says that urine is expelled, because patient doesn't know whether it's a urine or amniotic fluid. Something is coming out of the vagina. So always patient think, can relate that fluid to the urine as well, because in pregnancy also there is a stress incontinence. So we have to go for the speculum examination. So when you put the speculum, when you see by yourself that really white, all the white liquid is coming out of the vagina, pooling of leaking is there, or leaking is positive on examination, we can say it's a frank leaking. So fluid pools in posterior fornix, all will be filled with the fluid. If there's a frank leaking, fluid turns nitrogen paper blue. That's only a confirmation test you can do. And when dry, fluid has swirling pattern. So on after drying on microscopic slide, we can see something like this. So it's a positive clue. It's a this will going to help you in diagnosis. But honestly, during clinical practice, if we just see the pooling of fluid inside the vagina, inside the posterior fornix of vagina, we can clearly say it's a case of rupture membrane. Even you don't go for this microscopic examination of Fern, even you don't go for nitrogen paper blue, but of course these are the confirmatory tests that will help you aid in giving the diagnosis of frank leaking or premature rupture of membrane. So premature rupture of membrane can lead to preterm labor. Of course, most of the time within 24 hours, we will see that the patient is experiencing contractions. So contraction will start at within 24 hours of leaking. If not occurs within 48 hours, we cannot leave the patient like that. We have to go for the management of the patient. We have to decide the mood of the delivery, and most likely we'll go for the spontaneous one. If pregnancy is in 30 weeks, like in the third trimester, above 28 weeks, what is better that we can go for the DEXA administration. We want this lungs of the baby to be matured, right? If it's 36 weeks, 37 weeks, no need for DEXA. But if it's 28 to 34 weeks, in between 28 to 34 weeks, we have to give DEXA injection in order to mature the lungs of the baby. Now, this premature rupture of membrane, sometime in case of diabetic women and those who are having gestational diabetes, they're having lots of amount of amniotic fluid index. So AFI index is very high, especially in diabetic patients or the patients who are having sugar, baby sugar, or you can say gestational diabetes. So in those babies, we have a chances of cord prolapse, and cord prolapse is a surgical emergency. We can never let our patient, go into or lead into the normal vaginal delivery. It's not possible. We have to, prepare the patient just in case if there's a cord presentation, or if, of course, when there's a cord prolapse, we don't have anything, we ultimately take the patient to the operation theater. Then placental abruption, there may be a chances that a premature rupture of membrane can lead to placental abruption, but in those patients who are having eclampsia, in those patients who are having, having a strong history of smoking, so something like that. So in order to have a placental abruption, there should be history of, some fall or strong smoking history, or blood pressure, increased blood pressure, something like that. It doesn't mean that always premature rupture of membrane can lead to placental separations or abruption. It's not like that. Chorioamnitis, that's a very, very dangerous condition because of the leaking. Now the baby is more prone towards getting infection from outside the world. So that thing is called chorioamnitis. So we have a strong, indicator when the patient pulse is rising, when the patient is experiencing fever. These are the two important parameters on the basis of which we can decide, oh, the patient is now developing chorioamnitis, and that's an emergency. We have to, take out the baby. Otherwise, the baby will be infected very much. So before 32 weeks of gestation, of course, we have to mature the lungs of the baby. So we have to give injection DEXA. DEXA you can give 12 milligram intramuscularly, first dose, and then after 12 hours, we have to repeat the second dose of same amount, that is 12 milligram dexamethasone intramuscularly. Antibiotic cover, just to protect the mother from developing this chorioamnitis, we have to give broad spectrum antibiotic. If more than 37 weeks gestation, there is no need for DEXA cover, right? But we can of course provide this antibiotic cover if it's in between 34 to 37. So again, we have to give antibiotic, and this is gram bacilli GBS cover. So here, if you see, the patient is already having undergone this examination for this gram positive bacteria, that is a staphylococcus. There is no need of antibiotic, but less likely we have just GBS negative. Most of the time we will see GBS positive, and even if we don't know the status of GBS, we can always perform, but start empirical antibiotic at once, because antibiotic is must in case of frank leaking. So if we have a look at the questions. So here the question says, a 29-year-old woman, gravid 7, para 5 plus 1, admitted at 30 weeks gestation in labor room with leaking liquor for observation. So frank leaking is there, 30 weeks gestation. It's a time period where you should give DEXA to your patient, you should give antibiotic cover to your patient, and delivery of the spontaneous mode of the delivery should be decided. But here the question is asking, which of the following most likely confirm the diagnosis? How you're going to confirm whether it's a clear case of leaking, it's a clear case of premature rupture of membrane or not? So we have only one option. Just started, just receiving this patient in the labor room, we have to go for speculum examination. So once you do the speculum examination, and on examination you found the leaking plus or plus only, like you have seen by yourself that leaking is there, it means that this is a known case, and then you can go for the nitrogen blue testing, and you can go for this funding pattern over microscope. But first thing should be is sterile speculum examination. You have to go for speculum examination, because only on this speculum examination you will see by your own eyes that whether the leaking is there or not. If the pool of liquor is there in the posterior fornix of the vagina, you will say it's a clear leaking case. Okay, then we have this one. We'll go for the theory first. Then we have next syndrome, that is Asherman syndrome. It's not much in detail in MTB, so we'll go for AMBUS. Okay, here we have Asherman syndrome. The another word for Asherman syndrome is actually intrauterine adhesions. And why this endometrial adhesions or fibrosis is there in patient's body? Sometime following uterine dilatation and curettage. You must have heard this thing that always doctors are saying, please don't go for the dilatation and curettage, to some illegal department or to some illegal hospitals or clinics where they are doing criminal abortions, or where they are doing illegal abortions, where because legally it's not allowed. In UAE it is strictly not allowed, and in Pakistan also, if we are considering, I don't know about the status of India, but of course everywhere it's not a legal right to abort the patient until and unless there is a threat to the mother's life and the baby is having an anomaly or syndrome which actually causes the death of the baby soon after the delivery. Only in those circumstances this especially lawful abortion is applicable. Otherwise we will say all illegal abortions. So illegal abortions, of course there are some clinics which are doing these practices, carrying out of this illegal abortion, and they don't have safe abortion practices. So because of that, what will happen, there are more chances that those people will be there, those healthcare providers will be there which are not exactly trained, and they can perform this dilatation and curettage. And they, of course, for every procedure, for every surgical and medical thing, we have a proper technique to perform that procedure, especially the surgical procedure. So when healthcare professionals who are not trained and they are doing this dilatation and curettage, what they're actually doing, they remove the endometrial lining of the uterus as well. we should never remove the lining of the uterus while performing this DNC. So DNC should be very, it should be carried out in a very careful manner, that we should not remove the lining of the uterus. But of course, those who are not trained, they can remove the lining of the uterus. And what will happen? Later on, the patient will develop Asherman syndrome, and later on, the patient will not be able to reproduce. There will be no reproduction in that female, and that female can be infertile for their whole life, just because of this untrained health professional who carried out this DNC procedure. So that's why it's being the healthcare provider, it's our advice to the patient that never go, in such cases, for such cases, they should always seek medical advice. If there's a real threat to the mother, real threat to the baby, of course, we have a law which states that that will be a lawful abortion. But if it's illegal one, there is no threat to the mother just don't want to carry the baby, because she has so many reasons to say that they have like small baby at home, they cannot carry this one, and something like that. So of course nobody is allowed it. That is called illegal abortion, and for that sake, they're going into the wrong hands and can develop this thing. So it's our duty that we should provide this information to the patient, that they can harm themselves if they're not going to go in the proper trained setup. So this, this intrauterine adhesion Asherman syndrome, what is happening here? Some DNC might happen previously, and that during that DNC, the lining of the uterus is shed, and the lining once shed can never be regenerated, and the whole life the patient will become infertile. So following uterine dilatation and curettage, most common cause, sometimes it may be because of the infection as well, or STDs as well. So chlamydia is a very common infection that can lead to this fibrosis of the uterus. Now, clinical features, mostly patients are asymptomatic. Sometimes patients are having abnormal uterine bleeding. Sometimes patients don't have menses at all after this procedure, after DNC. That is called secondary amenorrhea. Of course, infertility will be there, recurrent pregnancy losses will be there if there is microfibrosis, and periodic abdominal pain. Every month they are having this pain, but they are not actually undergo this menstruation process. So that will indicate you towards Asherman. And when you do inquire the history, you will get to know that the patient must be having a history of DNC before, or must be having a history of STDs which were neglected or which were not cured on time. So how we are going to diagnose this patient? Progesterone withdrawal test we will do. The bleeding does not occur following progesterone withdrawal, given block the outflow tract. So of course, in normal circumstances, when you do this progesterone withdrawal test, what will happen? We give the progesterone to the patient, and when we stop the dosage, the withdrawal bleeding is there. So if in this case, the patient is having Asherman syndrome without, despite of giving this progesterone, the patient is not going to bleed on withdrawal, it means that there is something wrong in the patient's body, especially with the outflow tract. So there is fibrosis, that's why you cannot see the withdrawal bleeding. Or you can perform hysterosalpingiography. You will do the X-ray and you will see honeycomb appearance of the uterus. So that's a typical pattern on hysterosalpingiography. You can see if it's mentioned honeycomb appearance, think about Asherman syndrome. Confirmatory test, of course, you will see the uterus by your own, and that is hysteroscopy. Hysteroscopy to directly visualize, and you will see on hysteroscopy there are lots of adhesions, lots of fibrosis you can experience, you can appreciate on hysteroscopy. So that's a clear case of Asherman syndrome. What we are going to do with our patient? Sorry, 1 minute. So for the treatment option, we have stereoscopic resection of the adhesion if it's possible. We can go for the adhesionolysis. We can perform. We can do the resection of the adhesions. Or treatment is only indicated if patients are symptomatic. But if the patient is not symptomatic, we will not do anything. Say, for example, if the patient's family is complete, so you don't need to do anything. Only symptomatic patients should undergo this adhesionolysis. Other than that, we don't want that. So if we have, now we'll just look for the questions. Here the question says, a 33-year-old woman present with a history of amenorrhea for a year following dilatation and curettage. It's a clear case saying that the patient is now no more having menses, and that is followed by actually one dilatation and curettage because of abnormal uterine bleeding. The patient was having actually abnormal uterine bleeding, and because of that abnormal uterine bleeding, she has undergone this dilatation and curettage procedure, and after this procedure the patient is now having an amenorrhea, and it's been a year. So she underwent to both progesterone. She underwent to both progesterone and combined estrogen progesterone withdrawal test, and with no response. So of course, the first thing, in order to make a diagnosis of Asherman syndrome, we have to go for this progesterone estrogen withdrawal testing. If there is no withdrawal bleeding, if there is no bleeding on withdrawal of this progesterone, it means that the patient is a known case of Asherman. And her serum FSH level was normal. So which of the following syndrome is the most likely diagnosis? So it's a clear case with the patient is followed by amenorrhea followed by DNC. It's a clear case of Asherman. Okay. For the next one, we have to go for the theory first. We'll do this menopause from MTB handout 306. Okay. So for menopause, it's a permanent cessation of menses. We should know the mean age, especially when the patient is experiencing this cessation, and cessation cannot occur in a day or two. At least it will take the whole 1 year when the patient is experiencing spotting or, decreased amount of flow and all that. And, it will take usually 1 whole year to fully stop or cessation of this menses. So anyhow, the median age is 51 years of age. It's whoever is having age more than 51 years of age, you can always think about the patient is no more menstruating. And if the question says the patient has period bleeding or something like that, that will always be considered post-menopausal bleeding. And post-menopausal bleeding, until proven otherwise, will always be considered as a cancer. So there must be a cancer which is presenting in old age patient, those who have already undergone menopause and now they are presenting with the bleeding, they have chances of having endometrial cancer. So here they're saying permanent cessation of mensen due to permanent cessation of estrogen production. Now there is no more estrogen production. So what we can do most of the time, this menopausal women, they are experiencing, especially what we can say the menopausal symptoms in there. The patient, too much symptoms will be there, that we can provide them HRT, that is hormonal replacement therapy. But HRT is not a good thing to provide to the patients. But anyhow, those who are experiencing so much symptoms of this, especially this menopause, in those patients we can give HRT, and we can give this estrogen vaginal creams when they are having so much dry vagina because of the estrogen deficiency. But anyhow, we can only go for the symptomatic treatment. We should not prefer HRT, but if it's really indicated, then we may opt for it. And median age should be 51 years of age. So what actually the basic physiology behind this menopause? If we are saying early menopause, and we have this late menopause as well. So what do we mean by early menopause? The oocyte produces less estrogen and progesterone. LH and FSH start to rise, and shortening of menstrual cycle. So the patient who is having high level of FSH is one of the indicator that the patient is actually undergone the process of menopause. So what will happen when there is early menopause? Say for example, the patient is just 47 years of age or 45 years of age, still the patient is having time for the menopause, but the patient is presenting with amenorrhea, the patient is presenting with the symptoms of just like hot flushes and everything is there, which is mimicking like a menopausal symptoms. And the patient is patient wants family, patient wants to give birth to a baby. Then what will happen? The first thing we should do, that we should do this FSH level testing. If FSH is very high, so think about that the menopause has already occurred, because FSH is the one which is the main indicator. If it's too much high, the patient has very less chances or almost no chances to reproduce further in life. That's an important thing. So in early menopausal state, we always consider to go for the FSH testing. If follicular stimulating hormone is too much high, it means that there is no LH, there is no ovulation, because once LH surge is there, it's going to increase estrogen, and estrogen progesterone going to inhibit FSH and LH. But if FSH is so much high, it means that there is no estrogen, there is no progesterone in the body of the female that actually can go and do the negative feedback on the FSH level. So too much FSH means the patient is now no more fertile. So in late phase, what we can do, changes in secondary, especially sex hormones. This testosterone, this estrogen, progesterone, we have to see if they are less in amount, of course. they are not going to they are not going to help the patient, especially estrogen. They are responsible for the vascularization and this muscularization of the uterus. They are actually preparing the bed for the baby. So if they are not there, the sex hormones are not there, so of course the patient is not going to be in reproduction state as well. So we have these two main physiology. Once you see the too much high level of FSH, you can say it's an early menopause. And when you see decreased amount of estrogen, of course, later in life, say for example in early late 50s or early 60s, that's a late menopause. Anyhow, you will see decreased amount of estrogen and you will see increased amount of FSH. So what will be the symptoms, especially those who are experiencing this menopausal symptoms? There is menstrual irregularity, because just now and just for instance, the patient is not going to stop menstruating. There will be a passage of time when the patient is having some pre-menopausal symptoms where they are having menstrual irregularity. The spotting will be there, the number of days will be disturbed, something like that. That is menstrual irregularity, and there will be a passage of 1 year especially. There will be sweats and hot flashes will be there. Mood changes you are going to see in your patient. Dyspareunia, because of why? Because of the less amount of estrogen. Estrogen is responsible, to making the to help in laxity of the especially vagina. So when there is less estrogen, the vagina will be dry, and because of the dry vagina, the patient is going to experience dyspareunia, especially during intercourse. So women are symptomatic for an average of 12 months, but some experience symptoms for years. So mostly this whole thing happening for 1 year, but it can progress to more than 1 year, of course, as well. On physical examination, you will see decrease in breast size because of the deficiencies in sex hormone. You will see vagina and cervical atrophy, dryness of the vagina. You will see UV prolapse can also be there because the vagina will be so laxed. The elasticity will be gone because of the deficiency of estrogen and progesterone, and we will see UV prolapse. So UV prolapse can be a complete UV prolapse. Maybe you can see only the urethra is coming out from the vagina, or maybe you can see the rectum is coming out of the vagina. So urethrosil alone, rectocele alone, or maybe you can see both of them are coming out. So we can say it's a complete prolapse of procedentia. So what is atrophic vaginitis? It's a very common term. Vaginal epithelium is estrogen dependent. So once there is no estrogen, because the menopause has already occurred, the absence of estrogen causes thinning, presents as itching, burning, or dyspareunia. So once the patient, so for atrophic vaginitis, always look for the age of the patient, because it mostly occurring after menopause. So age must be above 51 years. And here you will see there will be thinning, there will be itching, burning. The patient must be presenting with this one. Of course, there will be no estrogen in the body of the patient's blood. That's why the patient is experiencing atrophic vaginitis. In this case, we have to give some local estrogen cream that can be applicable over the vagina, just in order to reduce this atrophic vaginitis condition. So let's have a look at the treatment part. Of course, menopause, because of the deficiencies in sex hormone, the bone mass density of the patient is going to be lost with the passage of time, and the patients are experiencing this osteoporosis problem. So osteoporosis problem, where the bone mass density is severely affected or is severely decreased, that's a main condition we will see in postmenopausal women, mostly in the old age. So hormone replacement therapy is an option we can give to these patients. We can give estrogen, progesterone to these patients. But again, there are some contraindications, and these contraindications are very lethal. Say, for example, those who are having estrogen-dependent carcinoma in their body. There are increased chances of getting carcinoma worse if they are going to take estrogen and progesterone. And if the patient is having history of deep venous thrombosis or history of pulmonary embolism, these patients also should not receive HRT. Otherwise, the patient can, can be there can be a worse DVT in that patient. So HRT associated with endometrial hyperplasia can lead to endometrial carcinoma. So see, if because of the use of estrogen, you will experience that the patient is going under endometrial hyperplasia, what will happen? This hyperplasia can lead to cancer as well. So there are a lot more chances of having this endometrial cancer just because of the use of HRT. And why the patient is using HRT? In order to minimize the symptoms in the patient. So it's better if we can just counsel the patient, but if it's really too much symptom, the patient cannot bear. And what are the symptoms? Symptoms are this one: mood changes, hot flashes, Of course, menstrual irregularity will not be there, but if there are mood changes, hot flashes, and dyspareunia, and because of that, if you are giving HRT to your patient, but remember that there are chances of having, endometrial carcinoma in those patients, so it's better to avoid. And if you really want to use HRT, use it for a shorter period of time. Okay, so this is all about menopause. So let's have a question. Last time my hand freeze actually was out. I didn't know that, so I won't be able to respond. So if you are asking something and I'm not responding, please message me on chat so that I get to know that this hand freeze is actually intact or not, because it's very quiet. Nobody is saying anything. Okay, so right now all of you are on mute. I can see. Okay, so let's have a. Okay, now I can hear you. I can hear. Okay, thank you.
Hello, Assalamualaikum.
Walaikum assalam. Oh, you are late today.
Yeah, I was late today. That is why I know what is talking.
Okay. Okay. So this question says a 50-year-old woman presented with amenorrhea for the last 6 months and has unwanted hot flashes. Now her age is 50 years. It's okay. We should not have all the time 51 years of age in order to make a diagnosis of menopause. We have early menopause, we have late menopause as well, but median age for our for our purpose of study should be 51 years. So here the patient age is 50 years, but she is having amenorrhea for the last 6 months and has unwanted hot flashes. So based on the symptoms, based on the amenorrhea, based on the age of the patient, we can think about menopause. Which of the following serum level would confirm the diagnosis? And you want to confirm the diagnosis, what you will do? So the first and foremost test which we usually perform just in order to make a diagnosis of menopause should be FSH level. So if you do the FSH level and the FSH levels are quite high, think about menopause. So here also what we will do, we'll go for follicular stimulating hormone testing. So once you do this follicular stimulating testing, FSH is very high than normal, then you can say it's a case of menopause. If still the patient is having amenorrhea for 6 months, in order to confirm the diagnosis of menopause, the patient should be having symptoms of at least 12 months, amenorrhea for 12 months. But it's okay. If FSH level is high and she's having 6 months, at least we can counsel her that now you are actually entering into a phase of menopause. Now the next question will go for the.
Excuse me, Dr.
Yes, dear. Yes, dear.
All the other hormones will be decreased. No.
LH and FSH will be increased, and estrogen, of course, progesterone will be decreased. Estrogen will not be there because if the level of estrogen and progesterone high, then what will happen? They are going to do negative feedback on the FSH, and FSH will be decreased. But if FSH is increased, it means that there is no estrogen in the body. That's why there is no negative feedback on FSH. Yes.
Okay, Dr. Hira, this to confirm menopause is above 50 is 12 months and below 50 is 24 months.
See, there is no criteria for 12 and 24 months. Just memorize this thing, that age should be 51 years, and before, early can be, early can
earlier when I was reading from the MRCGP past medicine, there is that one was above 50 is 12 months and below 50 is 24 months.
Okay, maybe you are right, because you are reading this MRCGP, but for our point of view in gynae normal routine practice, we have to have a history of 12-month amenorrhea and the FSH is high. We can say that the patient is undergoing now into a menopausal state. Maybe the patient age is 48 years old, but she should be having a history of 12 months amenorrhea. We will ask the patient, if you are experiencing 12 months, say for example now she's presenting to you and she's having amenorrhea for 4 months. Right, 48 years and amenorrhea for 4 months. So what we will do the FSH testing. We will ask the patient to wait for 8 more months. If bleeding is occurring, it means that you are still in the premenopausal phase, but your FSH is high. More likely in a year or two, you will be ended up into menopause. So we will just do the counseling. If you're saying it's mentioned in MRCGP like below 50 years, you can wait for.
Can do his pregnancy test, her pregnancy test.
Yeah, why not pregnant? That we can do, but it's very less likely in old. Those who are having high FSH, there is no need for even, and mostly when the patient is experiencing amenorrhea, they must have done this home pregnancy test as well. But in our case, in that case, if the patient age is like 40-45 years, we can still perform beta HCG, but above 45 it is very less likely. Until unless the patient has undergone IVF and there's a strong history that she was trying to conceive for many years, then of course we'll go for pregnancy test. Yes, but there is no harm anyhow in doing the pregnancy test. But logically, if the patient is 50 years or above 45 years of age, the first thing should come in our mind is go for the FSH testing. If FSH is high, then no need to do anything. We will just counsel the patient that still you are in the premenstrual phase. In order to label you as a menopause, we have to wait, at least for 12 months. And of course, FSH also already high, then we can say you are now entering into the menopause state. And after 12 months, maybe after 2-3 years or 4 years, if the patient is again having spotting and something like that, then we have to label the patient as postmenopausal bleeding.
Okay.
Yes.
Thank you.
Okay. So now we'll go to the cord prolapse. For cord prolapse, again, it's not very much in detail, so I will just take you through ambers. Okay, here we have this cord prolapse. So for cord prolapse, actually we have certain presentation. There are 3 types of umbilical cord prolapse, and of course, whenever it mentioned umbilical cord prolapse, always think about surgical emergency. It's a surgical emergency, but again, sometimes only cord is the presenting part. Sometimes cord prolapsed is actually evident. So there are 3 types on the basis of presentation of the cord. One is called overt umbilical cord prolapse, one is occult umbilical cord prolapse, and the third one is cord presentation. So what are the differences? Anyhow, you are not going to differentiate between all of these, but you should know that there are 3 types. There are 3 presentation, and what you're going to do in these circumstances. Although it's a surgical emergency, we have to take the patient to the operation theater straight away for the emergency cesarean if the cord prolapsed. So for the overt umbilical cord prolapse, condition in which part of the umbilical cord lies between the antecedent part of the fetus, mostly head, and the pelvic wall, causing rupture of membranes and acute life-threatening hypoxia for the fetus. So this is actually a prolapse. Overt umbilical, it's a true prolapse in which we can see the umbilical cord is actually protruding, and where it's protruding, the head of the fetus is there, and it's protruding from the side of the head, and you can easily appreciate that cord in the pelvis of the patient. So it's now actually protruded, and it's a life-threatening condition because the fetus can present with severe life-threatening hypoxia. So what we will do, most common form of prolapse in 0.5% of birth, we will see this one. Often seen in presentation anomaly, say for example, the one who is having breech presentation, or if there is any transverse lie, there is malpresentation, malalignment of the fetus, multiple pregnancies is there, or long umbilical cord, or fetal anomalies like polyhydramnios. In polyhydramnios, the mother is diabetic and the patient is, the fetus is having too much amniotic fluid. The AFI index is very high. Normal AFI index is like 12 to 15 centimeter. They are having 25 centimeter or 30 centimeters. It's too much, so much amount of fluid. So whenever the bag ruptures, what will happen? The cord prolapse suddenly. That's why when we are doing ARM, artificial rupture of membrane, and you can appreciate the polyhydramnios in the patient, we will always do the control ARM when someone is actually holding the abdomen of the patient, just in order to minimize this cord prolapse effect. Because sometimes it may happen. If sudden gush is there, the cord can come down. The prolapse can be there. So etiology often seen in presentation anomalies. We have seen there clinical features: an abrupt change from a previously normal CTG to one with fetal bradycardia. So as soon as the cord prolapse, you will appreciate on CTG there's a sudden drop in the fetal heart rate. So fetal bradycardia, bradycardia means if the fetal heart rate goes beyond below 120. So 80, 90, 70, these are typical bradycardias. And if it's above 160 beats per minute, that is tachycardia. So severe decelerations and occurring after the rupture of membrane. Of course, as soon as the membrane rupture and prolapse is there, you will see a sudden decrease in the fetal heart rate. So fetal heart rate maybe goes up to 60 beats per minute. Below 120 is bradycardia, and you will appreciate severe bradycardia on CTG machine. Now, diagnostic: vaginal palpation, thick pulsatile cord is palpable. Of course, when you do the examination, you can really appreciate the cord is there in the vagina. You can feel the pulsation of the cord as well. So treatment, what you will do, you will immediately you will ask the patient, or you will put the patient in Trendelenburg position. Fetus is pushed back into the uterus, immediate tocolysis using beta-2 mimetics, and of course emergency cesarean section. But normally what we do in our routine practice, There should be one resident who keep on holding the cord in her hand, and we straight away take the patient to the emergency theater by just keeping the hand over the prolapse, over the cord prolapses there. And the resident is not going to push the cord back, but it's just going to keep a firm pressure on the cord so that the cord cannot lose further or cannot come down further, or there should not be any harm to the cord. So the resident must be there, and it should be a resident, not a house officer or not a junior doctor. The resident who's like R3 and R4, they're actually doing this one, because most of the time this vaginal examination is also performed by the senior residents. So they are actually keeping the cord in position, and straight away we'll take the patient to the emergency theater. That is how we are doing in routine clinical practice. Then for occurred umbilical cord prolapse, what is this one? Similar to a word, but the umbilical cord has not advanced past the presenting fetal part. You can still feel the cord, but it's still inside the, you can still appreciate that it's inside. The head is palpable, and above the head, maybe slightly you can palpate the cord. But it's not descend. It's not prolapsed actually into the vaginal canal. It's still inside the os. You can still appreciate that it's behind the os. It's not protruding outside the os. So we can say it's occurred umbilical cords. And what we will do in this case, of course, the same presentation will be there. But here, what you will do is treatment with, here we will go for a spontaneous reduction of the umbilical cord into the uterus if mother is placed in different positions. So say, for example, if you put your mother in Trendelenburg position, what is this Trendelenburg position? A position in which the patient is supine with the head tilted down such that the legs are above the level of the heart. So just putting the legs above the level of the heart and putting this head especially down in the supine position, that is Trendelenburg position. And with the help of this position, you can just retreat the umbilical cord back into the abdomen. So we can perform this one, but anyhow, it's an emergency condition, because once the cord is there, palpable around the head, it may prolapse anytime. So we should be very vigilant over the CTG machine, because as soon as the cord prolapse, the CTG will show you immense, very much bradycardia is appreciated on CTG as soon as the cord prolapsed. So we should keep an eye and vigilant monitoring over CTG machine. Then we have third type, that is knuckle cord. Knuckle cord is most often caused by activity turning of the fetus. Most of the time you have seen that the baby is coming out having 2 or 3 turns of cord around the neck. So that is actually called knuckle cord. Single cord around the neck observed in 20%, and multiple cord loops around the neck in less than 1%. So again, it's not an emergency. We can proceed the labor, because umbilical cord is, of course, the length is too much and it's very flexible. So it can, having turns around the baby's neck. So that baby can absolutely go into the normal labor. There is nothing harm with the baby. But of course, if it's too much tightening of the cord, so before, as soon as the head comes out, we have to clamp the cord and we have to cut the cord at once and then take the baby out if there is too much tightening. But if there is not too much tightening, we can just take the baby out. So just have a look at the questions. Here the question says a 22-year-old.
In the previous cord prolapse, we were seeing in between the uterus and the pelvic wall or vagina.
It's vagina actually. It's actually, you can actually see that the cord is actually prolapsed and now it's in the vaginal canal. It should come out from the os. If it's behind the os, yeah, it's around the neck, around the head of the baby, or if it's a breech presentation, then around the butts of the foot of the baby, we can say it's just a presentation. But if it's, you can,
the cord prolapse in the vagina, but here they say in the pelvic wall. But
pelvic wall means the vaginal wall. Yeah.
Okay.
Here they mentioned pelvic wall. It's a vagina. Yeah. Okay. So here the question says a 22-year-old primary gravida presented at 30 weeks gestation in labor. Vaginal examination showed 7 centimeter dilated cervix. So 38 weeks, 7 centimeter dilated means she's in active labor. Fully effaced cervix and vertex is palpable. An hour later, the obstetrician noticed a loop of the umbilical cord below the fetal head. So below the fetal head, the loop of umbilical cord is there. So fetal heart 120, just up, borderline of the bradycardia. Which of the following is the most appropriate immediate management management, what you will do now, she can see it's below the fetal head. Below the fetal head, it any time can prolapse and the heartbeat can suddenly go to below 120. What you're going to do? Are you going to go for the vacuum extraction? You go for the cesarean section? You go for the forceps delivery? You go for the fetal monitoring? What should be your most appropriate immediate management? We will go for the cesarean section. Okay, next question says, for the next one, we have to go for the theory first. We have this threatened miscarriage. We have already covered this threatened miscarriage, but as Dr. Tyra, you have joined late, so we can just quickly go over this one. We have different types of pregnancy losses, but just for our recall point of view, we have discussed in detail the two of these, that is one threatened miscarriage and one is incomplete miscarriage. But I just quickly revise this one. You can go over the recording later. For threatened miscarriage, just remember there is a threat to the pregnancy, but still the pregnancy is secure. Still you can help the pregnancy to go forward because fetal heart rate is there, the patient is stable, everything looks okay, but there is a perisac bleed, there's a vaginal bleeding, and there is a threat if the patient is not going to rest at all. What will happen? The patient can lose the baby. So this is a threat to the mother that the patient is the fetus is under danger. That is threatened miscarriage. So for threatened miscarriage, what we usually do, we'll ask the patient to strict bed rest. We can give progesterone support. We will just hydrate the patient. Diet of the patient should be supportive, and everything should be encountered. So we will just give the expectant management, and the baby will be fine. But for incomplete abortion, what will happen? The pregnancy should be less than 20 weeks, and there will be sometimes there are fetal hearts, sometimes there are no fetal hearts, and some of the product of conception is expelled, some of the product of conception is inside the uterus, and you will easily examine. When you examine the cervix, you will see the os is opened. The os is opened. The patient must say in history that she has expelled some a product of conception, some tissues has already been expelled, and when you do the examination, os is open and you can feel some product of conception in the vaginal wall. And of course, when os is open, it means that still the uterus is not empty, and on the examination the uterus must be bulky in size. So that will give you a clue that something remains inside, something is expelled out. It means that it's incomplete abortion. But for threatened miscarriage, the os will be completely closed. There will be no opening of the os, because once the os is open, we can say it's an incomplete abortion, or it's the patient is going to expel soon because os is open. And once os is open, you cannot do anything. You cannot help the pregnancy. But once the os is closed, the baby fetal heart rate is there. Still you have a chance to secure the pregnancy just by doing the expectant management. So if we go over the question for threatened miscarriage, you can see here a 24-year-old woman present at 7 weeks gestation complaining of mild vaginal bleeding and lower abdominal pain, colicky in nature. Upon examination, normal vital signs, spectrum examination show the cervix, os closed. So if os closed and fresh bleed coming through the cervix, which of the following is the most likely cause? Still the os is closed. It means that the patient we still have a chance. And at 7 weeks, complaining of mild vaginal pain and low abdominal pain. See, this is because it's a recall. Something must be missing here, and it is actually fetal heart. So in order to make a diagnosis of threatened abortion, the fetal heart should be positive here. So fetal heart should be positive here, and os is closed. The definite diagnosis is threatened miscarriage. But if cervical os closed is not mentioned, then we may have this incomplete abortion, may have this incomplete abortion, we may have this inevitable abortion. There are so many types, but here it's clearly mentioned the os is closed and 7 weeks gestation, but heartbeat should be there. And this fresh bleed coming through a cervix, it's a perisac bleed actually, because once the fibrin coagulum is formed, once the baby is implanted, there is a bleeding from that area, and the clot is formed there, and that's called fibrin coagulum, and that area is actually bleeding. So this area is called perisac bleed, and mostly in the threatened miscarriages, we have seen this perisac fresh bleed. So it's okay. But if fetal heart rate is there and os is closed, of course, we're not going to do anything rather than only expectant management. We'll ask the patient to, for the strict bed rest. The movement should be restricted. She should not do some extraneous heavy work or exercise. She should be on the bed, and the legs should be raised, head should be down, and, strict input-output charting. Whatever she wants to take or do, she can do on her bed. So at least if the patient has no bleeding for more than 48 hours, then your patient is safe completely. completely in the sense that the sac, the perisac bleed will heal, or the fibrin coagulum will heal, and there will be no perisac bleed at all. So here, of course, septic abortion, this is not a case of septic abortion, because for septic abortion, the patient should be having sepsis symptoms. The fever must be there, increased pulse will be there, tachycardia will be there, but it's nothing like that. So septic abortion is ruled out.
It should be induced abortion.
Yes, but yeah, or no, sometimes it's not induced. Sometimes, there are a lot more, say for example, the RPOCs are there for more than 4 weeks.
Most
4 weeks.
Time, or maybe probability.
Yeah, most of the time we can think about induced abortion, but say for example, the RPOCs is there, especially in low economic social status. But if the RPOCs are there for more than 4 weeks, the more chances of septicemia will be there in that patient. Yes. Inevitable abortion, of course, in inevitable abortion, what will happen? Sometime this os is closed here also as well, but in inevitable abortion, the fetal heart rate will not be there. So that's why I'm saying this is an incomplete record, because fetal heart rate should be mentioned. If fetal heart rate is present, think about threatened miscarriage. If fetal heart rate is not there, of course, it's inevitable abortion, because soon after the os is going to be opened, naturally the patient can expel, and if patient is not able to expel within 4 weeks, we can induce the abortion. We can go for the medical abortion, we can go for the suction evacuation, we can go even for the DNC. Incomplete abortion, os should be open, there should be a history, something has already expelled out, the patient will give you a history that some tissue has already expelled out on examination, some you can feel in the vaginal canal, some you can see in the uterine cavity, the uterus is bulky, so that is incomplete abortion. Of course, threatened abortion, for making a diagnosis of threatened abortion, os should be closed, which is here, fetal heart should be there and intact, no corresponding. So fetal heart should be there, but here it's not mentioned fetal heart, but it's saying mild vaginal bleeding and lower. So mild bleeding is there. So based on these three symptoms, we can say it's a case of threatened abortion. But please remember, in case of threatened abortion, there should be intact fetal heart. Fetal heart should be there and os should be closed. And because of the perisac bleed, the patient is experiencing mild fresh red plate. That is a case of threatened abortion. We will just give the supportive treatment and pregnancy will continue. Okay, for the next one, we'll go for the theory. Postpartum hemorrhage, very important topic. We'll go for handouts 3 or 4. So for postpartum hemorrhage, as the name indicates, postpartum, so after delivery, soon after delivery, if there's vaginal bleeding and that is too much, it should be more than 500 ml. Normal vaginal bleeding is also there after delivery, and that is approximately 150 to 200 or maybe 250. So that much amount of blood is usually lost or during delivery. So that's a normal thing. But if the patient has lost blood more than 500 ml, so of course that is not normal, and we can say it's a postpartum hemorrhage. So primary PPH, which is soon occurring after the delivery of the baby, and there is secondary PPH when there is a time of 24 hours or maybe after 48 hours, the patient has undergone bleeding, so much bleeding, we can say it's a postpartum hemorrhage. So early and late postpartum bleeding, we will say this one. So of course, uterine atonia. A means without contraction. So uterus is not well contracted. So what we are doing when we are actually doing the postpartum examination of the patient, we are actually checking the uterus. Uterus should be well contracted. If uterus is not well contracted, you can give massage to the uterus and it should be contracted, or you have to go for the manual, checking by vaginally. You have to check maybe if there are clots around the, neck of the cervix, remove all the clots, and then you will experience yourself that the uterus is going to be contracted, or maybe you have to do syntocinon to the patient just in order to contract the uterus. So normally soon after delivery, the uterus should become contracted. If not, we can say that there's uterine atonia. And because of uterine atonia, that uterus which is not contracted, it's going to bleed a lot. So that is how the patient goes into PPH. Of course, when there is laceration over the vagina or laceration over the uterus or cervix, there will be bleeding from that area. RPOCs are there. Some placental parts are there, or some tissue products are there, so that is going to cause more and more bleeding. So there should be no RPOCs just after the delivery of the placenta. Just quickly have do the vaginal examination and make sure that there should be nothing inside the uterus, and uterine cavity should be empty.
Dr. Hira?
Yes, sir.
Early will be 48 within 24 hours and late after 24 hours?
Early means, see, if it's a primary PPH, soon after delivery. If it's a secondary PPH, again we have early and late. Early within 24 hours, and after 24 hours, it's late secondary PPH. And coagulopathy, if the patient is having any abnormal, any bleeding pattern disorders or bleeding disorders, of course, those patients are going to bleed a lot. So risk factors for atony, why the uterus is not contracted, maybe because of too much anesthesia. When we give too much anesthesia to the patient, the uterus is also getting relaxed, and there will be time when uterus is coming back to normal state. Uterine over distension, too much distension, there may be a prolonged or rapid labor, too early labor and too long labor. Both of these conditions can cause uterine atony. When you give actually augmented labor, like you're giving syntocinon to the uterus. So uterus is responding to the syntocinon too much, and then later on it's going to be sensitized and there will be no response at all to the syntocinon, and then the uterus can go into atony. Uterine leiomyoma, if fibroids are there, that fibroid uterus are having chances that they are going to be, that uterus is going to be less contracted. So what we can do, we can give manual massage to the uterus for a longer period of time as compared to normal patients. No concept today. Preeclampsia with magnesium therapy. In case if the patient is having preeclampsia condition, we can continue. We usually give magnesium support to the patient, and that magnesium actually can cause uterine atony. So we can think about this one. Of course, preeclampsia will be a special condition, but other conditions, say for example anesthesia, we usually give anesthesia to the patient. So that is how it's a very uncommon cause of PPH. So how we are going to treat our patient? For we have to examine the whole patient vagina, cervix should be carefully examined. By manual examination of the uterus, we can go for the compression massage over the abdomen. You can continuously give the massage to the uterus and it will get contracted. Or maybe we can give uterotonics like oxytocin, or we can give syntocinon, in other words, which we're usually giving in our routine practices. Operative management, that's a very last resort. When the uterus is not contracted at all, then maybe we have to check, and we can see uterine artery is the main reason from where the bleeding comes. So the embolization of the artery can occur. Maybe there are lots of RPOCs inside the uterus, we have to go for DNC. Maybe we can go for the B-Lynch stitch, where we can just stitch the uterus, and that is how we can perform only during laparotomy. We have to again open the uterus and we have to perform this maneuver. Maybe sometimes we can go for uterine artery ligation. We have to ligate the artery because the artery is a major source where the blood is coming from. Or last resort, we have this only hysterectomy, but we never ever go for this option, because uterus, the patient who's just now delivered a baby, will end up in massive hemorrhage. If we are thinking about hemorrhage, if we are thinking about hysterectomy, we should not opt for this option. But if you don't have any option, like the patient is bleeding like hell or continuous bleeding is there, what you can do, you have to remove, and that is called postpartum hysterectomy. And that's the worst thing ever can happen with the patient, because the normal patient who's having, if there's a controlled everything, the third stage of the labor is properly controlled, the trained staff is there, the patient should be monitored carefully, there's nothing like to be happening, hysterectomy, postpartum hysterectomy. But because of any negligence, and at any point the patient may end up in hysterectomy as well. But that's a last resort. That's a suture that can, B-Lynch suture. It's going to help in contracting the uterus, because it's going to make the uterus firm. So tightening will be there. And we want this uterus to be tightened, to be contracted, just in order to prevent bleeding. So this is all, or for, of course, when there is too much amount of blood loss, you have to cover the blood loss. You have to give RBC, red blood cells to the patient, FFPs, cryo can be given, just, so that the bleeding can stop. And this cryo and FFPs, you can see by yourself, they do actually the magic to the patient. So whenever the bleeding is coming out and you give this cryo and FFP to the patient, as soon as the blood comes out from the vessel, they will suddenly stop there, just because of this FFP and the cryoprecipitate. So they are actually the blood products we have to give, because there are lots of amount of blood loss here in this patient. So see, they have mentioned how you can give this Paxil. So Paxil RBC can increase 1 gram of hemoglobin. Say for example, you just now check the patient's blood and it's 8 grams. So by giving 1 Paxil, the hemoglobin will now become 9. By giving 2 Paxil, the hemoglobin now become 10. So it will be an increase in hemoglobin by 1 gram. FFP, of course, going to increase the fibrinogen and clotting will be there. Cryo will also do the clotting. Platelets will also do the clotting. So they are all the blood products we can always give to the patient who are having PPH. So let's look at the question. A 37-year-old woman, gravida 8. Sorry. Here it's gravida 8, para 7. At 38 weeks gestation, has history of recurrent postpartum. The 3 required blood transfusion. They required blood transfusion. Lots of spelling mistake because of OCR. She has no significant medical problem. Which of the following is the most appropriate preventive measure at delivery? So what you can do, she is gravida, of course, multi-gravida. They have more chances, and having this PPH. So 38 weeks gestation, has history of recurrent postpartum. Already the postpartum hemorrhage history is there in the patient's history. She has no significant medical problem. So what you're going to do the preventive measure at this time of delivery. She is now yet to deliver. What you can do to help the patient, as you already know, she's multi-gravida and she does have a history of PPH in previous pregnancy. So either you are going to deliver the patient in operating room or you are going to perform an elective cesarean section, or you're going to perform active management of 3rd stage of labor, or you give the patient preload of crystallized fluids. What you will do? What do you think, Dr. Taira?
In the operating room.
In the operating room?
Or
any other option?
After the C, perform active management of stages.
She is multi-gravida, right? Maybe she can deliver the baby before taking into the operation theater. There will be, there will be aggressive delivery.
If there will be any risk of bleeding and something for that, we can take her in the operation.
Okay, what about perform active management of 3rd stage of labor?
Yes, this is also an option. I told you.
Yeah, so this perform active management, that's a better option. Why? Because we usually have labor room which is close to the operation theater. So there is no, no need of having this multi-gravida who is having previous history of PPH, just to deliver the baby in operation theater. It's no, delivering the patient, normal patient in operation theater has certain special circumstances. Say, for example, the one where you do the external cephalic version. Breech presentation, and recently if you do the external cephalic version, those patients can be delivered in operation theater. But this patient, if you just do the active management of 3rd stage of labor, what is active management? You take out the placenta with the control cord compression, just empty the whole cavity, do the massage of the uterus, give the syntocinon properly. So that is how you can control. No need even to do anything if there is proper handling at the 3rd stage of the labor. And if there is improper handling during that stage, the risk started from that point. So no need for the operation theater, of course, but do the active management. So here the correct answer should be perform active management, because that's the whole management of labor. This 3rd stage is the one where the most patients.
I was thinking about the Pakistan, where it takes a lot of time to the OT and asking the OT people.
Yes. And it's not easy, it's not easy to occupy
and stretching and stretcher and everything, lot of time.
But again, occupying the OT, just having this thing in mind, it's not a good idea as well. It will cost a lot of cost benefit to the hospital. We cannot just engage the OT just in order to have this thing in our mind that the patient may end up in this one. So it's not like that. We can control, because there are medical treatment where on the basis of that we can control PPH. The hysterectomy and B-Lynch and everything is the last resort to control, and nothing has happened. Nothing can control. Then only we can think about it. Okay. For the next here, see, a 40-year-old woman has just delivered her 7th child at 38 weeks with 4 kg. Just delivered. Multi-gravida. Good sized baby. Baby boy vaginally 10 minutes ago. The placenta is still in place and she starts to bleed profusely. See, the placenta is still intact. The placenta is still inside, and now she started bleeding, and she bled how much? 800 ml of blood. So more than 500 is coming under the diagnosis of primary PPH soon after delivery. So this is a case of primary PPH. Which of the following best describe this case? Of course, soon after delivery, 10 minutes is there, still the placenta is inside. It will take at least half an hour to come out for the placenta. Of course, the placenta is coming out early than 30 minutes, but the maximum time period is 30 minutes. And still the placenta inside and the patient is bleeding more than 800 ml, it means that this is a case of primary leakage. For this one, we have to go for the theory first. Gestational hypertension is not there in MTB much, so I will take you to MBOS. So gestational hypertension. See, in order to make a diagnosis of gestational hypertension, the pregnancy should be more than 20 weeks. It should be in our mind first thing. Because if the patient is hypertensive before 20 weeks, then this is not because of the pregnancy. This is because of the chronic hypertension of the patient. Patient must be having a known hypertensive patient. Even though if the patient does not know herself that she's a known case of hypertension, but she's presenting with increased blood pressure, and in order to say increased blood pressure, the patient should be having two readings of increased BP, 140 by 90. The BP should be more than 140 by 90 on two different occasions, and she's less than 20 weeks. For example, 14 weeks or 16 weeks, we can say you are a chronic hypertensive patient. You must be having hypertension before pregnancy, and that is actually continuing now. But if the patient presents to you after 20 weeks with two readings of increased blood pressure, two readings of, then we can say it's a gestational hypertension. Then we can say, okay, this hypertension is now in you because of the developing baby. It's not because of your body. It's not because you have previously had hypertensive history. No, it's just because of the baby. So then we can say it's a gestational hypertension. And then when this hypertension is accompanied with the symptoms, the blood things is going to be disturbed. Blood investigations, for example, you will see low platelet, you will see hemoglobin low count low, you will see some other symptoms, headache, blurring vision. Then you can say, oh, it's a preeclampsia now, it's developing. And when the patient is having fits because of all these things, we can say now the patient is having eclampsia. So there are certain parameters on the basis of ground of which we can say this gestational hypertension is now converting into preeclampsia, and preeclampsia is now converting into eclampsia. But just in order to say gestational hypertension, just remember that the patient should be above 20 weeks of gestation. Then only we can say it's all because of the baby. And the patient must be having two increased blood pressure readings, that is more than 140 by 90. Then only we can say it's a gestational hypertension. And two readings must be on two different occasions or 4 hours apart. Like once you do the BP, it's 140 by 90, more than 140 by 90, and you check after 4 hours, it's still more than 140 by 90, then you can say it's a gestational hypertension. So if we go back to the question, here it says a 24-year-old primary gravida is found during antenatal care at 22 weeks gestation to have a blood pressure 140 by 95 in two different measurements documented 4 hours apart. So now she's 22 weeks, of course. By mentioning 22 weeks, now it's clear in our head that this patient is not a known hypertensive patient. Something has happened after pregnancy. So 140 by 95, increased blood pressure 4 hours apart. Her urine test for protein was negative and she was asymptomatic. So it's okay, protein is negative, symptoms are not there. Which of the following is the most likely diagnosis? But she has blood pressure, increased blood pressure. After 20 weeks, then the diagnosis should be, what should be your diagnosis? Preeclampsia, we cannot say preeclampsia. For preeclampsia, there are certain criteria, especially the blood investigations. Chronic hypertension should be less than 20 weeks. Transient hypertension of pregnancy, transit means it's continuing, like again, and it's not a proper term. So diagnosis is gestational hypertension. This also, a 39-year-old primary gravida attended.
How to differentiate it from preeclampsia? There will be proteinuria.
Of course, in preeclampsia, CBC will be disturbed a lot. There will be low platelet count. There will be low hemoglobin. There will be urine in the protein in the urine, right? There will be proteinuria.
And there will be at the end of the pregnancy. It will be at the end of the pregnancy, towards the end of the pregnancy.
Sorry, it will be what?
Towards the end of the pregnancy, completion.
Yes, mostly in the third trimester, patients usually present with preeclampsia. Yes, but in the above 28 weeks, till any week of gestation, you can see preeclampsia. And one fits is there, of course, that's eclampsia. Okay. So a 39-year-old primary gravida attended her routine prenatal visit at 39 weeks. 39 weeks. She denied any headache, So once it's mentioned, she denied any headache, visual changes, it means that preeclampsia is excluded. Nausea, vomiting is not there, abdominal pain is not there, protein is negative in urine. Vital signs, blood pressure, just now 160/90. At 39 weeks, if the blood pressure is 160/90, it's okay, right? It's not okay in that case, but it's again we can say it's just a hypertension, gestational hypertension, because rest of the vital signs all over the visit, blood pressure was extremely okay, 120/70. Throughout 9 months of pregnancy, she was having normal blood pressure. At the end of the pregnancy, she is now coming to you showing her increased BP, but no signs of preeclampsia at all. No headache, no visual changes, no urinalysis, negative protein, everything. So which of the following is the most likely diagnosis? Because she is having raised BP, ideally the second reading of the BP should be checked after 4 hours. Maybe she's now in any of the stress. Maybe the transportation stress is there. Maybe another stress is there. So what we can do, we can just relax the patient and check the BP after 4 hours. Ideally, it should be like this. But after checking the blood pressure after 4 hours, if still the BP is high, then we have to label this patient as a gestational hypertension, because we cannot say this patient is having preeclampsia. She's now at the full term. So based on the answer choices, you will decide your answer. Eclampsia, chronic hypertension, gestational hypertension, or superimposed preeclampsia. If any option is there which says check the BP again after 4 hours, that should be the best answer. But if it's not there, so of course it's not a case of eclampsia, it's not a case of chronic hypertension, it's not a case of superimposed preeclampsia, it's just a gestational hypertension. But ideal answer should be check the BP again after 4 hours. For the last question, we have to go for the theory first. It says breech presentation, P03. Okay. For breech presentation, of course, the presentation of the baby is very important to know. We have 3 types of breech, especially when there is a frank breech, when there is a complete breech, when there is a foot-length breech. When we say it's a frank breech, fetus hips are flexed. You can see the flexion of the fetus hip with extended knees bilaterally. So knees will be extended bilaterally. Both of the knees will be extended, and hips will be, of course, flexed. We can say it's a frank breech. So you can appreciate the butts of the child on examination. We can say it's a frank breech. When we can say it's a complete breech, fetus, hips, and knees are flexed bilaterally. Knees will be flexed, and of course hips are flexed. So hips flexed, knees flexed, we can say it's a complete breech. But if the knees are extended, we can say it's a frank breech. And when we can say it's a foot-length breech, of course, when you can just palpate the foot of the fetus. So we can say it's a foot-length breech. Fetus feet are the first, one leg, maybe if one leg is palpable, you can say it's single foot length. If both legs are palpable, you can say it's a double foot length. So normally we have this frank breech. Normally we do have this frank breech position, but any type of the breech can be there. So what you can do? What we can do, mostly before 34 weeks, when you ask the patient to squat, to do especially this what we can say do sajdas. It means just put the head down so many times in a day. That can change the position of the body, but most likely it is very less likely that after 34 weeks the breech is going to change the position. 34 weeks is majorly the time period where the position can be changed, but after 34 weeks, like at 36, 37, 38, there's less likely chances the baby is going to change the whole position. It's not possible. Then what we can offer to the patient, we can offer to the patient this external cephalic version. What we can do in external cephalic version, we will just rotate the baby from outside. We'll try to rotate the baby with the help of the hands, and it should be up after 34 weeks, but of course before 38 weeks. But external cephalic version, it's risky sometimes, because we can end up in malpresentation, and of course this malpresentation will be straight away elective cesarean section. Anyhow, nowadays breech is also delivered via elective cesarean section. We will never ask the patient to go for the normal delivery if the presentation is breech. Previously, we may deliver the breech baby, but nowadays in hospital settings, we never advise the patient, especially the primary gravida who's having the first baby, will never encourage those patients even to go for the trial of this normal delivery for the breech one. In private settings, no option. In some government settings, if the patient is multi-gravida, you don't have any option. The patient is 9 or 10 centimeter dilated, the breech is already coming out, you don't have any option. You just assist the breech delivery. Breech delivery will happen by themselves. You don't need to do anything. Yes, dear.
Sorry for interrupting. Can you please repeat the difference between complete breech and frank breech?
Yeah, see, in frank breech, knees is extended. See, the legs are straight. So knees should be extended, but of course hips will be flexed. But in complete breech, both of these, see, knees are also flexed, the baby's legs are also flexed, and baby's hip is of course flexed. So if both of them are flexed, we can say it's a complete breech.
Okay.
But if knees are extended straight legs, you can say it's a frank breech. And footling, of course, foot is there, 1 foot, single footing, double foot.
And let me tell you, I have done once primary breech delivery.
Primary, oh, I have done so many multi-private breech, but not a primary.
alone in the clinic, private.
Oh, no.
18 years ago, maybe.
Because see, for the breech delivery, you are only actually assisting, right?
Breech.
Just assisting the baby, and the baby will come by its own. We have nothing to do with the breech.
Yeah.
But of course, once head sucks,
but
then
you have to rotate his head and put your finger in his mouth.
Yes. I thought so. When the head is stuck, then of course we have to perform maneuvers. That's the thing. But it's very risky because upon investigation, research, the chances of having stillbirth during this, especially breech delivery, is high. So now we are properly trained, we know the maneuvers and everything, but before that, the baby usually ended up in having a stillbirth after this. Yeah. So we have two things. So straight away, you take the patient for the cesarean, elective cesarean. Of course, it will not be an emergency cesarean, but of course, if the patient is in the labor room having a breech, then you can take to the emergency theater, emergency cesarean. Otherwise, it should be elective cesarean. Or we can ask the patient to go for the external cephalic version, but most likely the patients are not usually willing for the external cephalic version because of the side effects of this external cephalic version. Sometimes external cephalic version may happen. I know one procedure. And I was there assisting in that procedure. What was happening? We already took the patient to the operation theater. We were performing breech emergency cesarean. But what happened soon after giving anesthesia, the whole patient body was relaxed, and one of the senior residents, she was doing pelvic examination, and what she do during examination? She rotated the whole body because the body was so relaxed, the abdomen, the uterus was so relaxed. She just removed the whole thing, and patient was fully dilated because she was ended up in the emergency cesarean section because of the breech. But once she put the finger on the senior resident, and she just rotated the whole baby, and the whole baby come out, just on the OT table. So that was a normal delivery conducted under spinal anesthesia.
Wow.
So sometimes things happen like that.
That was internal cephalic version, huh?
That's internal cephalic version, of course, because she introduced the hand and she rotated the whole body, whole fetus like that because the uterus was so relaxed. Okay, so looking at this question. They're saying a primary gravida at 37 weeks gestation known to have biconvate uterus. Complaints of subcostal discomfort and fetal kicking is appreciated in the lower abdomen mainly. So of course, sometimes fetal kicking, sometimes fetal heartbeat, where you are going to actually, hear this heartbeat. And of course, when you do the Leopold maneuver, we will just have a look at the Leopold maneuver. You can just by palpating the abdomen, you can see what is the baby's presentation. You don't go for the ultrasound just in order to confirm the cephalic baby or the breech baby. You can do by your own hands also by doing physical examination. But of course, it will require some techniques, it will require some experience. So see here the Leopold maneuver done, and it shows global soft presenting part with sluggish allotment by first and second pelvic rib. So let me show you these grip first. So it will give you a nice clue actually. I have downloaded one image for you. This. Okay. If you can just appreciate this one, this is a Leopold maneuver. How we are checking the grips, how we are checking the position of the baby by doing per abdominal examination. So this is called the first maneuver of Leopold maneuver, and that is fundal palpation. What we can do, we can just appreciate by doing like this. We can exactly know where the fundus, near the fundus, just put your hand side by side and observe or just feel what's exactly the presenting part over the fundus. So see, this is how you appreciate that these are the butts of the patient. This is the first maneuver. In second maneuver, you put your hands just parallel to the abdomen, and that's a lateral palpation. This is called lateral palpation. This is called fundal palpation because you put your hands on the fundus. Fundus means abdomen. So you put your hands on the fundus of the patient and you appreciate what is this part. You just feel, observe. And when you put your hands laterally, this is called lateral palpation. This is the second part of the maneuver. Third part, you will just put your hand. If it's a cephalic baby, you will just do the pollic grip, and you can easily appreciate the head of the fetus, which is moving between the fingers and thumb of your hand. So this is pollic grips. And the final one, the fourth maneuver, is the pelvic grip. When you put your hands in opposite direction, see the opposite direction as compared to the first maneuver, you will put your hands in opposite direction and you will appreciate again the head. So that is the fourth maneuver of the newborn. So the first grip and the second grip will give you a clue where the butts of the baby and where the head of the baby. So if you see the soft globular portion, which is which is floating in between two hands, that's most likely a butt area of the baby, like the buttocks. But if you see just straight this one, pollic grip, you can easily appreciate the head of the fetus in between your forefingers and your thumb. That is a pollic grip. So here the question says, Leopard maneuver shows global soft presenting part. Cephalic or head of the baby is not a soft one. It's very hard. When it says global soft presenting part, think about butts of the baby, because that's a very big portion and it's very soft, and sluggish ballotment can be there by first and second pelvic grip. You can easily rotate the butts in between your two hands on lateral palpation. So fetal heart detected at the level of the umbilical cord. So of course above you can see the fetal heart rate. So which of the following is the most likely fetal presentation? So in first and second pelvic grip, if you can appreciate the butt portion or the soft global portion, always think about the breech baby. Always think about the breech is there, because the butts is the presentation part. So which of the following is the most fetal presentation? Face presentation. Face presentation you cannot appreciate on per abdominal examination. For face presentation, you have to do PV, per vaginal examination, and you can feel the nose, you can feel the chin, you can feel the lips of the baby. Then you can say it's a face presentation. Bro presentation, again, you will not be appreciated on per abdominal examination. When it's a maneuver, it means we are doing actually the per abdominal examination, but these presentations are not appreciable on per abdominal examination. You have to do per vaginal examination in order to say this is a face presentation or this is a bro presentation. Shoulder presentation and breech presentation. Again, shoulder presentation you have to do for the per vaginal examination. You cannot appreciate on per abdominal examination. But breech is the one which you can easily appreciate on per abdominal examination. If by doing first and second pelvic grip, you see the globular portion, the bulky portion, the soft portion moving in between your two hands, that's most likely a breech presentation. Butts are there now. And if you see if you do the pollic, the butts you cannot, the butts will be a too much area. They will require the too much area. You cannot easily grip the butt in your one hand. You cannot move the butts in between fingers and thumb, of course. So pollic will not be possible in breech presentation. Only first and second. Fundal grip and the lateral grip is appreciable in breech presentation. So this is the clear presentation of breech baby.
Excuse me, Dr. Hira.
Yes, please.
Can you please repeat this?
Which part?
This is the question.
See, the question is saying that this primary gravida at 37 weeks, she's presenting with having this bicornuate uterus. This bicornuate uterus is just mentioned here to disturb you. Anyhow, she is pregnant now. So bicornuate is not going to help you here. But most likely when the patient is having bicornuate uterus, there will be a malpresentation of the baby. Sometimes it do happens, the baby is malpresented. So this is a clue for you that this is not a normal cephalic presentation.
Normally?
Yeah, they will deliver normally, of course. Because bicornuate is on the upside, it has nothing to do with the downside, right?
Bicornuate means it had two cavities?
The cavity, sometimes the upper portion can be divided into two. But once the baby is fully there, 37 weeks, it's only inside the cavity, and that's all going to be fused. So you can differentiate.
There will be only one cavity, huh?
One cavity, yes. That's why the
bicornuate means the little horns from the upper side.
Upper side. Okay. Exactly.
Not two separate cavities, canals.
No. Because here the baby is already there at 37 weeks, huh? So you can easily appreciate only one cavity. Now, fetal kicking is appreciated in the lower abdomen, mainly kicking in the lower abdomen. It's another clue for you. Kicking. in the lower abdomen. It means foot must be down. There is
Yes.
no head down, right? Foot must be down. Now, when you do the Leopold maneuver, which is actually performing for examining the abdomen parabdominally. Leopold is the parabdominal maneuver. It's not a parvaginal, parabdominal. So when you do the parabdominal maneuver, first
What
and
is this
second
maneuver?
grip.
Did we do this like now? We did do this like now.
Leopold maneuver, these are the 4 diagrams which I have just shown you. This is the Leopold maneuver. You just perform the lateral grip, you perform the fundal grip, you perform the pollic grip, and you perform the pelvic grip. So these 4 maneuvers are coming under the heading of Leopold maneuvers.
Okay,
Leopold maneuvers are divided into 4 parts. First
Okay.
maneuver, which is called fundal palpation. Second maneuver, which is called lateral palpation. Third maneuver, which is called pollic palpation. And fourth maneuver, which is called pelvic palpation. So these are the parts of, you can say, parts of Leopold maneuver. So and these are all the parts of per-abdominal examination. Okay, these are the things which you do on per-abdominal examination. So here in this question, it says when we did this Leopold maneuver, what we have observed that by first and second pelvic grip, we appreciate the butts of the baby. Are you getting me? We appreciate the bottom part of the baby, not the head part. Why? Because saying shows global soft presenting part. Cephalic, if cephalic presentation is there, if the baby's head is down, that should be a very strong, firm rounded portion, which you
But
can.
here we have soft parts.
Soft part, yes.
Parts, huh?
Which are, of course, which should be butts, because it's mentioned clearly, shows global soft presenting part with sluggish ballotment by first and second pelvic grip. So in first and second pelvic grip, we actually do the maneuver by both hands. If you can see here, we use our both hands. So if butts is down and we are using our 2 hands and we can appreciate the butt is moving in between our 2 hands, we can say it's a breech presentation, right? Because the baby's butts are down. But in order to say the cephalic presentation, the head should be, you can just control the head with 1 hand by moving your head in between thumbs and the fingers. Yes. So of course, in this case, the head is not down. That's why the pollic maneuver is not mentioned. Only which maneuvers are mentioned? First and second, where you can just appreciate the presenting part between your 2 hands, lateral grip and the fundal grip. So maybe in these 2 presentations, they have observed sluggish ballotment of soft global presenting part. So the soft part must be the butts. So third clue is there in order to make a diagnosis of breech. First clue, the
but Dr. Hira, for breech presentation,
yes,
it will be a frank breech.
Let me show you again.
It will be a frank breech with extended knees. So the kicking is at the top.
See, that is the other thing. Whether it's a frank breech or it's a complete breech or it's a footling breech, when the baby delivers or when you do the ultrasound, then you can observe, right?
No,
but on
they are saying the kicking is
kicking is in the lower abdomen, then it should be a footling breech. Yes.
So in the question, they have said we can appreciate the kicking at the fundus, near fundus.
Appreciate in the lower abdomen.
So
it's a footling breech, na? It's a footling breech. There are chances of footling breech. When you do the per-vaginal examination, you will be much more clear. Okay.
If the kicking is appreciated in the lower abdomen, then it is a footling breech.
Footling breech, yes. But anyhow, the breech is there, na? Because
it's confusing, na? Yeah. See, it's confusing. If the kicking is at the fundus or up there, then there will be the frank breech or.
You cannot appreciate the fetal foots. You cannot appreciate the fetal feet. You can only appreciate the butt on first and second grip. Because first and second grip, just look at this picture. Because here they are actually emphasizing on the per-abdominal examination. What we are actually examining the baby on per-abdominal examination, we actually palpate the butt's portion, like the bottom of the baby or head of the baby. So forget about the feet. Feet only when you do the per-vaginal examination. If you can feel, you can say it's a footling breech. Here they have mentioned that the fetal kicking is lower abdominal cavity. So you have a clue. You have a clue for footling breech. But here it's not about the footling breech. Here it's about the presentation, whether it's a cephalic or it's a breech. So if it's a breech, it's obvious that on the lower part of the body, you will appreciate some soft portion that should be moving in between your two hands. There will not be a pollic maneuver. That's not possible at all. Right? This is clear, right? You cannot appreciate the head of the baby if it's a breech. Head will be up, right? So that is how. So here in this question, they are actually emphasizing more on the grip of the patient. First and second grip, you are actually having this bottom part of the baby which is moving in between two hands. And of course, you have a clue that kicking is there in the lower abdomen. You have a clue. So these are all clues which are pointing towards to make you.
But they are showing the Leopold maneuver shows double shot presenting with sluggish development by first and second pelvic grip. This first and second pelvic grip are the third and fourth in the picture?
No, first and second is the first and second here. This one. First is this one. You can easily appreciate. So here they can appreciate in between two hands. See, in the second one, lateral one. So lateral one, think about this butts are down and this head is up. So this in between two hands, you can easily differentiate this one. But again, anyhow, you can perform all the maneuvers. And in pollic, you cannot do the pollic here. In this case, breech. So this first and second maneuver, of course, the all four maneuvers should be there. So they're just giving you a clue that we have seen or we have observed some ballotting portion in between these two. So it's think about this one. If this butt portion is down, and of course knees are in this position. Knees are in this position. Let me show you. Think about this one. Think about this one. Now what you observe? Just put your hand around the abdomen and think. Imagine. You will see your hands will do what? There will be the baby will be moving. The butts will be moving between two hands. You cannot put your one hand and just feel the head of the baby down. So just think about, just look at this picture and imagine your hands position on the sides of the abdomen. That is the second grip you are performing.
No, but they are saying it first two pelvic maneuver. The maneuvers are to perpetrate at the fundus.
The first one is fundus. So what should be the finding at the fundus? Look at the picture again. What should be the finding at the fundus? You can easily differentiate the globular round portion, but that should be formed here over the fundal one. The fundal one, you will just feel that, just rotate this baby and think about this hard portion. You can easily appreciate on the top. So the globular portion is not on above. It should be down on fundal, and it should be side by side when you do the lateral examination.
Of course. No, but they are saying in the first two maneuvers, means if they will say the last two pelvic maneuvers,
you are confusing yourself a lot. See, ballotment by first and second, they have only mentioned sluggish ballotment by first and second maneuver. So they have not mentioned. If you want, they should give you the first maneuver finding is this one, the second maneuver finding is this one. But forget about this one. Right? They are not going to give you everything in the recall. Of course, in recall you're not going to get everything, and in the MCQ also they are not going to give you proper thing like first maneuver we find this thing, second maneuver we find this, and they will not say like that. You have to extract from the meanings what is actually.
This is first the second pelvic grip. It's okay. I will think about the two maneuvers.
See, you cannot go in much deeper point. Anyhow, it's quite obvious. When you feel the globular portion, it means that these are butts. When you see the firm portion, hard portion, you can see it's a head. Yeah. So that's a clinical practice. This is quite a clinical experience question rather than a theory one. Because once you consider the theory, you have to have every result after each maneuver. But that is not possible in the MCQ, of course. They will give you, they have already given you 3 clues here. So it's a clear question. Nothing too much in there. Yeah, you're getting why they have mentioned all over first and second grade. You have sluggish ballotment. So sluggish ballotment, soft portion. Think about butts. Okay. Most likely. Right? And anyhow, looking at the answer choices as well. Face and bro are the pervaginal. So you cannot say it's a breech presentation. So all of the other presentation are actually appreciable on pervaginal examination. Only the breech and cephalic is the one which you can examine on per abdominal examination. Got it?
Yes. Thank you very much.
Okay, no problem. Okay, thank you so much. So that's all for today. See you tomorrow. So tomorrow we will be doing at 7:30, inshallah. Okay, no more holidays. Thank you everyone. I'm just going to stop this.
For explaining this to me in such detail.